Prioritization and delegation. Prioritization, delegation are two fundamental skills that every nurse must master to ensure patient safety and effective teamwork. These are not just abstract concepts for a textbook. They are the real-time, high-stakes decisions you will make every single shift. Good choices in these areas separate chaos from calm. Chaotic, dangerous environment. Calm, controlled healing. They are the twin pillars that uphold safe, competent nursing care. This will give you clear, simple rules for exams and practice. We will break everything down into easy-to-understand parts. So, what is prioritization really? Prioritization is deciding which patient needs your attention first. Look at your entire group of assigned patients and ask, who is the sickest right now? Constant mental sorting. Identify the most urgent, life-threatening issues first. Then address less critical tasks. This skill directs your time and energy to where it is most needed, preventing adverse outcomes and stabilizing patients in distress. Priorities shift. Reassess constantly as conditions change. And what about delegation? Delegation is entrusting a specific task to another team member. It is more than telling someone what to do. True delegation transfers authority while you retain ultimate accountability as the RN. Patient scenarios usually contain age, gender, diagnosis, and a modifying phrase. Age, gender, diagnosis, and the crucial modifying phrase. The modifying phrase describes what is happening right now. It is the most critical element. Example, 10-year-old male with hypospadias who is vomiting bile. Age, gender, diagnosis are secondary. The real alarm bell. Vomiting bile. Acute, unexpected, potentially life-threatening. Demands immediate attention. Zero in on the modifying phrase. First step to mastering prioritization questions. The first and most frequent rule: distinguish acute from chronic. An acute issue has sudden onset, is new, or is an exacerbation of a pre-existing condition. A chronic problem is long-standing and often predictable. In almost every case, acute takes precedence over chronic. An acute asthma attack is higher priority than managing a chronic COPD patient with expected oxygen saturation. Second, fresh post-operative patients. Any patient in the first 12 hours after surgery is high priority. This period is unstable and high risk. Anesthesia effects linger. Airway can be compromised. Hemorrhage risk peaks early. Vigilant monitoring and immediate intervention are essential. A return from OR 12 hours is a top priority, even if they appear stable. Third, and most powerful, unstable, overstable, always. A stable patient has a predictable condition. Their picture is not changing unexpectedly. If the question says stable, treat them as stable. Stable examples: post-op greater than 12 hours, local or regional anesthesia only. A or B level lab abnormalities are not immediate threats. Phrases like ready for discharge, admitted longer than 24 hours, or unchanged assessment indicate stability. Expected symptoms in chronic disease remain stable. Stable patients can often wait or be delegated to an LPN. Unstable patients have unexpected or life-threatening changes and require immediate care. Keywords include acute, unstable, newly admitted or diagnosed, and less than 24 hours since admission. General anesthesia patients are considered unstable. C or D level critical labs, such as dangerously low potassium, are unstable. New confusion can signal hypoxia. Unstable. Always unstable. Hemorrhage. Extremely high fever. Hypoglycemia. Pulselessness or breathlessness. These are medical emergencies. Drop everything. If two patients seem equal, use organ vitality as a tiebreaker. From most vital to least: brain, lungs, heart, liver, kidneys, pancreas. In unwitnessed disasters, pulselessness, breathlessness, or fixed dilated pupils may receive a black tag due to survival odds. In disasters, the goal is saving the greatest number. Safe delegation is critical, and NCLEX tests it thoroughly. LPNs handle stable, predictable patients, not unstable ones. Do not delegate the core nursing process: assessment, planning, evaluation. LPNs can collect data, RNs do the initial comprehensive assessment and interpret it. Never delegate the first of anything: admissions, discharges, transfers, or initial teaching. LPNs cannot start IVs, hang or mix IV meds, push IV meds, administer blood, or manage central lines including flushing and dressings. Admission, discharge, and transfer assessments are RN only. LPNs cannot take verbal orders from a physician. Tasks needing advanced judgment or in unstable situations belong to the RN. Assigning an unstable patient to an LPN is always incorrect. LPNs implement the RN plan for predictable outcomes. They can maintain and document basic IV flow initiated by an RN. They can administer oral and subcutaneous medications. They can perform chronic wound care. They can suction and provide tube feedings for stable patients. They help with day-to-day tasks that advance recovery. That is the essence of safe delegation. Delegating to UAPs requires strict scope awareness. UAPs provide essential support but never perform assessments. They can collect vitals and blood glucose but cannot interpret them. Do not delegate meds, with rare topical exceptions, most treatments, assessments, or condition charting. Appropriate: ADLs, basic safety, I&O, positioning, and routine finger sticks. In pharmacology, learn common and dangerous side effects. If unsure, use logic. Pick a side effect in the same body system as the drug. CNS drugs: drowsiness, dizziness. GI drugs: nausea, diarrhea. If you must guess for a PO drug, choose a GI side effect. Never tell a child medicine is candy. In OB, check the fetal heart rate first. In Med-Surg, LOC matters, but airway is the priority for intervention. PEDS rules: call it normal. Pick older age, pick the easier task. A 6-month-old is more likely rolling than sitting unsupported. Avoid absolutes like always, never, only, all. Duplicates are usually both wrong. If two are opposites, one is often correct. Umbrella strategy: choose the broad option that covers the most. Worst consequence rule: prevent the most serious outcome. When stuck, the Sesame Street rule can help. Do not expect the minimum number of questions. Prepare for a long exam. You are not expected to know everything. Focus and reason. Remember, acute versus chronic, post-op less than 12 hours, unstable versus stable, organ vitality order, delegation rules, FHR first, PDs quick rules. Read carefully. Breathe. Apply the rules. You have the tools. Trust your training. Trust your reasoning. Walk in with confidence. Good luck.